Okay, sir. Yeah. You can go. So, what is your number? Yeah, right. Good. I don't think you need to take notes because I'm not going to talk anything new. So everything is there in the book. Okay. So I'm just going to make it a little easy for you to read, right? So you go and read the book. Don't waste time in writing. Okay. So welcome you all. I think I'll be audible. Basically have a good vocal cord, so so I can talk loudly without mic. I'll just talk. Um, Laryngeal anatomy is one of the very peculiar anatomies. Generally, anatomy is like a dry subject, right? So conventionally, people teach you like that. So it is a very dry subject because there is, nothing new. It's everything is there. But if you ask two questions to why it is there the way it is, that is number one question. Number two question, why should I know that? Okay, you're not gray. You're not going to write any book on anatomy. Whatever is there, you're not going to write every single structure. It is the surgeon, any good surgeon should know the anatomy well. So then only you can do surgeries on that. Okay. So you need to know why I should know this particular structure is here. Why I shouldn't know this. So that question is number two question. If you ask these two questions, then anatomy will be very easy, right? So number one, you know why it is there, then you won't forget anything. Number two, you know why you should know that. Okay, then you need not know everything else. Okay, there are a lot of things there which you don't have to know about it. All right. Okay. So now we start the anatomy as a story, a good story. So once upon a time, then the story should start like that, right? So once upon a time, some 4 lakh years ago, we were animals, right? By evolution, we became humans, right? So then we were just eating and drinking. Only these two functions we need to do. And these two functions can happen simultaneously, right? You can drink at the same time you can breathe, right? So that is the way even now the babies live. They can drink milk, they can feed, at the same time they can breathe. So for that reason, the epiglottis is going up just behind the uvula, right? So you have separate channels for breathing and as well as eating. All right. So then we evolved, right? We don't have to eat all the time. At least majority of us don't have to eat all the time. Maybe some can eat all the time, but majority of us don't have to eat all the time because we know how to produce food. We can save it for our everyday living. So maybe 2 times or 3 times you can eat. Rest of the time don't have to eat. So you don't need the complete tubing for eating purpose. So for that reason, the esophagus is a collapsed structure. So normally it is collapsed. So whenever you eat, the food bolus goes down and peristalsis happen, this closed structure open up. All right. Only that time you need a food pile. The rest of the time there is no function for esophagus that can be collapsed. But you need to have a complete tubing for breathing because you've been breathing for all the time. Okay. So you have a complete tubing in the name of trachea, there is a C type of cartilaginous ring, and it is a complete tube. All the time it is open. Okay? But when you eat, you are not breathing. Alright? So that particular time you can use the advantage of the space in the trachea for eating. So when the food bolus goes down through the esophagus, the anterior wall of the esophagus bulges anteriorly. So that is, the posterior wall of the trachea is membranous. For that purpose, it is membranous. Because it is membranous, when you eat, the esophagus bulges out anteriorly, taking advantage of the space which is there for some time, not doing its function of breathing. Alright? That's good. So now we have two types which is fantastically occupied less space and simultaneously working together for its functions. Right? But another problem arrived because we humans evolved and we developed the function of speaking. For that reason, we need to have some strings, okay, something called vocal cords. That has to sit on something. Alright? So that is the reason we have a complete ring in the breathing pipe. Okay, so that is the only complete ring. Okay, so now you have a complete ring. Okay, so now you know why this is a complete ring, because all the structure is a D ring. You have posterior divisional part, but here you can't have that because you need to have something sit on the trachea. Cricoid. Alright? So you need to have some socket for another structure to sit over it. So that is the reason posteriorly it is a thick and long lamina. The cricoid lamina is otherwise called signet ring shaped lamina. Okay? Do you know what is signet ring? Signet ring will be like, you have a ring which broad base and a small ring which can be an arch. So this is the small arch, anterior arch, and posteriorly you have a thick lamina, okay, for the arytenoid to sit over it. Alright, so now we have developed a good solid cartilage which is called cricoid cartilage, and over it there is a small cartilage called arytenoid which is sitting over it, so that you can have a connection this is a thyroid cartilage, because this has to go and connect to the midpoint of something in the thyroid cartilage. Okay, so now you have this vocal cords which is getting connected anteriorly together, that is called anterior commissure. Okay, and the area between these two cartilage is called posterior commissure or posterior glottis. Clear now? Right. So we have developed this. Okay, fine. We have developed it, but have some function. You can't just keep two strings there. It has to work, right? Then only you can move this both way so that you can produce some voice. All right. So it has to be closed or adducted. For that, you have something called interarytenoid muscle. Okay, so interarytenoid muscle can pull this together, so you will have adduction function, so the vocal cord can be closed. Okay, this is one part. At the same time, you can have another function. It's like a lever, pulley. So because this structure is something like a triangle, okay, you can have something here so that if it is pulled like this, both sides, then this can approximate, right? So both sides, if it pull this can approximate because the structure is like that. So you have a lateral cricoarytenoid muscle. So that is again this adducting, right? For adduction, you have two muscles. One is interarytenoid, another one is lateral cricoarytenoid. Two muscles you have to close. All right, and you have one muscle from here, both sides. That is posterior cricoarytenoid. Okay, just to pull this apart. Alright, posterior cricoarytenoid. So that is the only muscle which abduct the vocal cords. Okay, now you know two muscles which is adducting and one muscle which is abducting. Okay, the function is over. But for some time you need to raise your pitch, right? In that situation, you need to have a tensor because you need to tense the string. Then only you can have a high pitch. Okay, so for that reason, you have a thyroarytenoid. Thyroarytenoid. Okay, so the medial part of thyroarytenoid is vocalis muscle. Okay, so you have a tensor here. This is thyroarytenoid, and you can have another situation where you can tense the vocal cord, where you have something here outside something here. If you pull this, if you pull the thyroid cartilage, what will happen? The thyroid cartilage will tilt like this. When it tilts, this will strengthen, enlarge, right? So you have another tensor that is called cricothyroid. That's it. Okay, you have two muscle to adduct and one muscle to abduct and two muscle to tense. That's it. That is the intrinsic muscles of the larynx. Over. Okay, now you have these structures, right? These structures developed. You have a cartilage there, you have a cartilage here, you have a cartilage there. Okay, it has to be connected, right? Otherwise, you can't hang somewhere like this. So it has to be connected. Okay, so to get connected, inside what you have is a membrane, which is a cricovocal membrane below. So from cricoid to the level of the vocal cord, there is a membrane. This is cricovocal membrane, or otherwise called conus elasticus. Okay, so that membrane is attached to the upper border of the cricoid cartilage to the level of vocal cord. At the level of vocal cord, it is thickened to form the vocal ligament. Right? So that is the inside boundary of the membrane, okay, and if another membrane which is above connecting the cricoid to the thyroid cartilage, that membrane is like, it's not like a conus membrane, it's not a triangle membrane, it's a quadrangular membrane because the structure is like that. So that is a quadrangular membrane. The lower part of the quadrangular membrane forms a vestibular ligament. Okay, now you have two ligaments. One is vocal ligament, another one is vestibular ligament. So these two forms the true vocal cord and the false vocal cord. Clear? So this is the attachment, and also this is the medial border. Okay, so the quadrangular membrane comes and stops at the level of the false vocal cord, that is vestibular ligament. The lower conus elasticus comes and stops at the level of the vocal cord. Then there should be some space in between, right? So what is that space? That is ventricle. There is a space which is ventricle, and ventricle can go inside, that forms saccule. Okay, so I'll come back to that part little later. Why there should be ventricle? Why not it is a complete one single membrane which can go from up and down. Anyway, you need to just have a connection. Okay, there is some reason why there is a ventricle. Okay, so now you come to the external part. Externally, this kind of membranes which also rigidifies, because just a membrane cannot hold the whole cartilages, right? So here you have thyroid cartilage, cricoid cartilage. Okay, you have a cricothyroid membrane all over. In the midline, you have to have a condensed membrane so that it forms a ligament. So this is cricothyroid ligament. Okay, now this is okay. Here you have continuous tracheal rings. That has to be also connected, right? So you have a membrane, that is cricotracheal membrane. This holds this two. Above also you need to have something, right? Then only it can be held. So here you have boat-shaped bone, that is hyoid bone. Okay, so you have a thyrohyoid ligament. All right, so all these three ligaments holds the whole thing. Okay, and also you have the membranes everywhere, so that is called thyrohyoid membrane, cricothyroid membrane, cricotracheal membrane. So now you have connections externally and internally, right? So when you have such connections, you have some boundary medially, some boundary laterally, then there should be some space, right? Okay, so what are all the spaces there? Because you have a conus elasticus medially and the quadrangular membrane medially, laterally you have a thyroid cartilage lamina. All right, so the space between these two is called paraglottic space, because the glottis is there from here to here. There is some space. Okay, you have a paraglottic space. The paraglottic space has this vocalis muscle and also some space there. Okay, why should you know about this space? Because whenever there is a tumor which involves the paraglottic space, that means that involves the muscle as well. So you have a fixity of the cord. Then obviously the reading will go up. Okay, and also this anterior part, the paraglottic space goes like this, and goes and ends somewhere. That is For example, this is the thyroid cartilage. You have epiglottis goes up like this. Alright? So that epiglottis is not doing its function like what it did for animals, because it's not going up to the level of the soft palate, right? So it is not doing anything like a two channel, because you need some space for articulation of your sound. The vocal cord, the sound comes up, it needs to be articulated, then only you can produce a proper sound. So for that reason, the larynx itself is descended down. Okay, in babies you have larynx almost at the level of C2 to C4, but in adults it will come down to C4 to C6. Okay, so obviously this epiglottis has become like a one structure which is just sitting there, because it is not going to do the purpose of doing what it was doing. Okay, so it is something like a flappy structure. It has to be steady. So for that reason, you have something here, here, which is connecting the epiglottis to the hyoid bone. Okay, so that is hyoepiglottic membrane, which is like this. Okay, so because it is connected like this, here what you have is already, you know, this thyrohyoid membrane is already there anteriorly. Okay, so this part superiorly, this is hyoepiglottic membrane, anteriorly hyoid and thyrohyoid membrane, and posteriorly you have a stalk of epiglottis, and there is a space here. So that is called pre-epiglottic space. This pre-epiglottic space is connected to the paraglottic space anteriorly. So any disease there can come to paraglottic space disease can go into pre-epiglottic space. Okay, then if it goes to pre-epiglottic space, obviously the staging will go up, because it can easily go to a extralaryngeal space. So for that reason, you need to know these two spaces. Okay, now you know the cartilages, you know the muscles, and you know the membrane, and also you know the spaces. So everything clear, right? So now you have everything pakka. Okay, there should be some covering, right? So the whole body is covered by skin. The inside, everything is covered by mucosa. Okay, so then there should be covering of mucosa internally, right? So what mucosa is there in the larynx? Like in any other respiratory part, it is a respiratory type of epithelium. So ciliated columnar epithelium, because it has to beat, right? So you need to have some cilia to beat the air down and up. So ciliated columnar epithelium. Okay, but here in the vocal cord, you don't need anything of that kind, because this function is something different. This vocal cord's function is not to beat, but to produce some sound. It has to be taut. Okay, so vocal cord alone is squamous epithelium, stratified squamous epithelium. But any stratified squamous epithelium outside will have keratinization. So there will be shedding. But here you can't have shedding, right? Because it is somewhere else the squamous epithelium is sitting. Nowhere else except outside you won't have squamous epithelium. For example, from here, if the squamous epithelium goes into the middle ear where there is a respiratory type of epithelium, you will have cholecystomas. You can't have something like that. So this is a non-keratinized stratified squamous epithelium. Okay, if it is not keratinized, then this will be very rough, right? It can't move both sides. It can't have something like friction effect, right? Because there is no respiratory type of epithelium. There is no mucus glands. There is no mucus secretion, right? So it can't happen. So for that reason, there should be some lubrication. You need some mucus glands somewhere else, because that space just above is free. That is called ventricular saccule. You have plenty of mucus glands which secretes mucus for the vocal cord to function. That is why this is called oil can of larynx. You understood now? Right. So you now know the mucous membrane also. So you know the coverings also, you know. Okay, fine. Everything is fine. Now it has to function, right? You need to get a order from the brain. Then only you can function. You need to have a good nerve supply. So nerve supply, how it happens? So basically the nerve supply has to be sensory and motor, right? So first we'll think about the sensory. Sensory supply inside is, one is, basically it is from the vagus, right? It is from the vagus. Okay. The vagus has got two nerves to supply the larynx. Superiorly, the nerve is coming inside is called superior laryngeal.
Phone it. Simple, sir. Doctor. Sorry.
Know the nerve supply, right? So nerve supply is two nerves. One is superior laryngeal nerve, another one is recurrent laryngeal nerve. Only these two nerves supply. Okay. So here you have from vagus, from nodosum, there is a nerve comes like this. It is superior laryngeal nerve, which pierces the thyroid membrane at the midpoint. You should know this, okay? Because when you do a, for example, if you are doing a laryngeal drop down, if you want to pull the larynx down, then you can do a cut here. Release the membrane, bring the thyroid cartilage down. In that case, you will have to do the cut along the superior border of the thyroid cartilage. Then, obviously, you won't cut the nerve there. Okay? So, for that reason, you should know where it enters. Okay? So, this enters, goes inside, that is going inside. That supplies sensory to the larynx above the level of vocal cords. It goes in and supplies above the level of vocal cord. Okay, fine. So you have vagus now going down, and here at the level of arch of aorta in the thorax, it gives a branch that is called recurrent laryngeal nerve. The recurrent laryngeal nerve goes like this along the tracheoesophageal groove. It goes up like this and entering into the larynx just behind the cricothyroid joint. So again, this is very important landmark, cricothyroid joint. Okay, so why you should know this? Whenever you do surgery here anteriorly, in case if you are elevating the cricothyroid muscle both sides, if you are elevating like this, so you have cricothyroid muscle here, okay, cricothyroid muscle. If you are elevating it, you can go up to the level of the cricothyroid joint. You cannot cross that. As long as you are medial to the cricothyroid joint, you will never touch the recurrent laryngeal nerve. You will be always, you don't have to see the nerve. Okay, you are sure that you are being medial to that nerve and there won't be any problem. Okay, so it goes like this and gives sensory supply to the level of vocal cord and below, and also it gives motor supply to all the muscles, all the intrinsic muscles, except why no, that question comes. Why? Because I used to memorize this all the nerves are supplied by recurrent laryngeal nerve except cricothyroid, Huh? It is outside the larynx. It is here. It is here. It's not inside. So, intelligently, the nerve vagus gives a branch from the superior laryngeal nerve that comes and supplies here. Because it is coming externally, it is called external branch of superior laryngeal nerve. Alright? So now you know all the nerves which is supplying. Okay? The only nerve which is the only muscle which is doing abduction is posterior cricoid. Okay, I used to wonder how a single nerve can do adduction and abduction. The nerve is not doing that because the muscle is positioned in such a way. If you contract, automatically this opens. The muscle just stimulates the nerve just stimulates the muscles. That's it. Okay, so all the muscles are supplied by recurrent laryngeal nerve except cricothyroid. Cricothyroid is supplied by the external branch of superior laryngeal nerve. All right. So now you know the nerve supply. Okay. So then blood supply. Okay. Whenever there is a nerve which is supplying, there will automatically you will have something along with this neurovascular bundle. So the superior laryngeal artery goes along with this. The same point, it goes along with this, and also from here the lymphatic drainage also happens through that level. Okay, whenever you have a disease in the supraglottis, the lymphatic drainage will happen through the thyroid membrane, which goes to the jugular digastric node, this level 2 node. And the vocal cord level, there is no gland, there is no lymphatic drainage, so there won't be any drainage in the vocal cord level. If you go to subglottis, then it can come down through the cricothyroid membrane. What else is there? Cricothyroid membrane. So it can come out through the cricothyroid membrane and drain into the level 3-4 nodes. Okay, so this is about the lymphatic supply, and the vessels is one is coming from the superior laryngeal nerve, that is the branch of superior thyroid artery. Okay, and also you have, along with this you have a inferior laryngeal artery. So in the lower nerve it goes like this, that is from the inferior thyroid artery. From the inferior thyroid artery, inferior laryngeal, superior laryngeal, it forms a plexus there and supplies the larynx. Both comes together and forms a plexus and supplies the larynx. And also there is a branch from the inferior thyroid artery which goes along the nerve into the tracheoesophageal groove. Okay, goes down and gives branches to the trachea like this. Maybe once in 2 rings, 3 rings, it gives a branch, something like this, to the trachea. The trachea, it goes submucosally and forms a plexus. Okay, one comes here, one comes here. You have a plexus submucosally inside. Why should you know this? Whenever you resect the trachea for anastomosis, you elevate this from the esophagus. Posteriorly, it is in the esophagus. If you go along the perichondrium of the tracheal rings, then you will not injure the recurrent laryngeal nerve and the vessels. Okay, but you have a vessel supplying here. For example, if you want to cut here, then if you bring this up to anastomose, you have the vessel here and which is giving submucosal plexus. You will have to just cauterize this. That's enough. Okay, you don't have to cauterize everything, then you won't get blood supply for the newly anastomosed site. So you will have to be very careful in seeing that particular vessel that is coming from the inferior thyroid artery. You will have one by one vessels going across the trachea, that is going intercartilaginous space, going inside, and submucosally it forms plexus. All right, this is about the blood supply. Okay, now you know the nerve supply, blood supply, and lymphatic drainage. Okay, so in case the disease process, when there is a disease, where all it can go. For example, if there is a cancer larynx, then where all it can go. In case if it is there in just the mucosal level, it can just go around. For example, there is a tumor in the vocal cord. It can go around. It can't go superiorly to the supraglottis because you have a division of ventricle. This is embryologically different part, these two, so it won't go up. It can go round. That is again between the two vocal cords. You have something called Broyles ligament, which is a strong tendon. Okay, so the disease can't spread from one vocal cord to another vocal cord. Can't means like it will be little restricted. It doesn't mean that it won't go, but the anterior commissure mucosa is placed in such a way it can invaginate into the subglottis. So the disease going to the subglottis from the anterior commissure is more common than going to the supraglottis. At the same time, the anterior commissure, it is almost directly attached to the thyroid cartilage. So disease can escape into the pre-epiglottic space through the porous of the stalk of the epiglottis. Once it goes to the pre-epiglottic space, it can go extralaryngeal. Okay, so this is how the disease spreads. For example, if it goes laterally, it can involve the paraglottic space. Then it can have fixity. Then the mobility will be restricted. Then obviously
So
you will have
can't
to
it go supraglottic?
What we can't?
Why can't it go supraglottic?
Yeah, because the supraglottis is there is different two structure. The quadrangular membrane comes and forms the false vocal cord, vestibular ligament. Here it is the conus elasticus, which forms the vocal cord, the vocal ligament. Okay, in between there is a ventricle. It can't jump from here. Now, obviously, once it goes to the paraglottic space, it can involve transglottic. You understood now? So, because that is a space, the whole thing can be involved. Then you call it a transglottic disease. All right. Once this is involved, then you will have to see why you should know all this. Not just to do laryngectomy. I think one of the easiest surgery in ENT is laryngectomy. You remove everything and throw it off, right? But if you want to do a conservative laryngectomy, if you want to preserve the function, then you should know where exactly the disease spreads, how it spreads. Then only you can preserve the structures. Okay, and once the disease in the vocal cord level, it can't spread everywhere, right? So that is the reason it is having a fantastic survival rate. Okay, because it is just in the mucosal level. Okay, how? Because you have a mucosa. Okay, mucosa is squamous epithelium, and from the mucosa you have a next. What is there? It is lamina propria. Okay, so in the lamina propria you have Reinke space. That space is between the vocal ligament and the mucosa. Okay, so they'll confuse with intermediate, deep layer. Don't go into all these things. Anyway, it's not needed for you. So there is a space, that is Reinke space. Okay, after that there is a vocal ligament. After that there is a paraglottic space. Okay, so it can just be there. Why there is a Reinke space? Because this has to vibrate. For that there is some cushion is needed. So you have a Reinke space there. Okay, only that much you should know about the vocal cord and the mucosa. I think I've fairly covered everything. In case if any questions you can ask.
Between the mucosa and the superficial layer of langa is the Reinke, or between the superficial and the other layers of langa, Reinke space.
Yeah, between the superficial and the other lamina. So that's why you don't get confused with all the lamina propria layers. See, anyway, it's not going to be a big issue for you. So there is a mucosa, Denki space, and then ocal ligament, ocalis muscle, paraglottic space. That's it.
So in the flexor plate, the branch which is going to trachea, it has a name for the branch.
Tracheal branches. Tracheal branches. That's it. Because only up to the level above it comes like this. When you go below, it comes from the bronchial artery and it comes from the innominate arteries, subclavian. So all this will have tracheal branches. Okay, but thyroid can't give tracheal branch everywhere till the carina. Get anything else?
Function of ventricle and cycle. All space.
Yeah, that's an oil can of that is oil can. Okay, so for it gives lubrication for the vocal cord.
If it is asked in the exam, what is the tensor of vocal cord? You have to go for cricothyroid or thyroid?
Both are tensors.
The sacule will be somewhere level above the ventricles.
Sorry.
The location of sacules.
Yeah, so it goes like this and goes little up. Sacule goes little up so that it can come out through the upper border of the. See, in case if it is going like this, it can go like this between the upper border of the thyroid cartilage and the thyroid membrane. It can go up. Sometimes it can also happen like that.
It's marginal zone, sir. Why is that?
Huh?
Marginal zone.
Marginal zones. Yeah, because there is a zone where you can't clearly demarcate. So the disease can jump from here to here. Okay, in the marginal zones. For example, the glottis is, what is glottis? If you ask to define glottis, what is glottis?
Anteriorly epiglottis, posteriorly interretinoidal vein, and laterally where the two open cords.
What anteriorly epiglottis? Epiglottis is such a long structure. You can't give epiglottis as anterior
commissure.
Anterior commissure. Okay, anterior commissure, and then
Two open cords.
so what is true vocal cord? What is the boundary for that?
Medial free margin of medial margin.
So from only from the free margin you call it glottis. Below the free margin it is not glottis. Huh? Yeah, 5 millimeters from the free border. Okay, because the 5 millimeter is squamous epithelium. So that divides the glottis. So below the free border you will have up to 5 millimeters. That will be the squamous epithelium. Okay, that is glottis. And above it is the free border of false card. Okay, so the ventricle also comes into the glottis. So now we generally, what we use rhima glottis, we call it only between the vocal cords. It's not so. From the 5 millimeters from the free border below and above up to the level of the vestibular ligament or false card. So that is glottis. Anterior commissure, anteriorly, posterior commissure, posteriorly, or posterior glottis. Okay, above is the supraglottic structures, below is subglottis. Subglottis is up to the level of the lower border of the cricoid cartilage.
Any doubts?
Anything else?
His anatomy is very, very important. Sir has made it very simplified, and he has given the complete concepts, and that's very important, more than the why